awa, ko taki tēmu tuku waka, ko poikara tuku iwi, ko tipiritu tuku hapu, no Rarotonga ahau, ko Georgia Tiaono Whitta toku ingoa. Greetings everyone, my name is Georgia Tiaono Whitta and I am a fourth year BMedSci Hons student at the University of Auckland. I am from the beautiful Cook Islands and today I will be presenting a summer studentship that occurred over the summer of 2019 to 2020, titled Investigating Ethnic Inequities in Cerebral Palsy, a Pilot Study. Listed below here are the co-authors and supervisors for this project. Firstly, ngam hiki e nei rōpū, I'd like to give thanks to the following groups: Starship Foundation, TKHM or Te Kupunga Hauora Māori Department, the New Zealand Cerebral Palsy Register, and the Paediatric Orthopaedics Department in Auckland, as well as my wonderful supervisors and wider team. The NZCPR stands for the New Zealand Cerebral Palsy Register. This is a database established in 2015 that allows for the collection of information about people living with cerebral palsy in New Zealand. Following the expansion of this register to around 1,300 participants, the NZCPR saw that it would be a great benefit if this information were to be analysed and put into use in the clinical inequity settings. Following discussions with a TKHM staff member, TKHM collaborated with the NZCPR to investigate cerebral palsy in Aotearoa. Cerebral palsy is a very common physical disease affecting children worldwide. Many different events can cause cerebral palsy to manifest, and these events manifest as motor delays in developing brains and affecting motor development in children. International reports have examined links between cerebral palsy prevalence and minoritized ethnic groups, low socioeconomic status, and other factors. However, there have been no such reports in Aotearoa, New Zealand. Therefore, the aims of our study was to describe the demographic, birth history, and clinical features for non-Māori and Māori patients with cerebral palsy in the NZCPR. In addition, to establish health equity principles for the NZCPR. The first stage of this project was data collection, and this involved patient ascertainment into the NZCPR between the years of 2015 and 2019 in the 3 DHB areas of Auckland, Waitemata, and counties Manukau DHB. Next, data refinement involved the information gathered in the NZCPR to be extracted into an Excel spreadsheet and then cross-checked for accuracy and duplicates. Finally, data analysis was undertaken using split file analysis and SPSS to provide descriptive summaries for Māori and non-Māori separately. Although many variables were collected by the NZCPR, we chose to just investigate the following: age and gender, socioeconomic deprivation, severity of CP, type of CP and the timing of the cause of CP, ACC funding status, and birth weight and gestational age. Firstly, we will be looking at the socio-demographic results we recorded. A total of 68 Māori and 489 non-Māori were included in this study. Most participants were in the age range of 6 to 19 years, followed by 20 years and above, and our smallest group were those aged under 5 years old. This graph illustrates the distribution of Māori and non-Māori living with cerebral palsy in the 3 DHB areas investigated. From here, it can be seen that non-Māori are more likely to be residing in Auckland DHB compared to Māori, whereas Māori with CP are more likely to be residing in counties Manukau DHB compared to non-Māori. This may prove important when looking where to direct equity achieving services. The New Zealand Deprivation Index is an area-based measure that assigns a deprivation decile to an individual based on their residential address. Decile 1 to the left-hand side indicates the areas of lowest deprivation, whereas decile 10 to the right-hand side indicates the most socioeconomically deprived areas. This graph illustrates that the proportion of Māori living in the most deprived areas was more than double that of non-Māori, whereas the proportion of Māori with cerebral palsy in the least deprived decile 1 was less than half that of non-Māori. Our data also showed that Māori are more likely to be born extremely low or very low birth weight compared to non-Māori, as well as being born extremely or very preterm. Both of these are risk factors for cerebral palsy development. However, it's important to note that the absolute numbers calculated in these statistics was relatively low and therefore may not be fully represented on the population. Now we're going to be looking at the clinical characteristics of cerebral palsy. The most common timing of a cerebral palsy event in both Māori and non-Māori participants was an event occurring in the pre- or perinatal period, which is within the first 28 days of life. However, postnatally acquired cerebral palsy after the first 28 days of life was far more likely to occur in Māori compared to non-Māori. Examples of postnatal or acquired CP events are infections such as meningitis, injuries, or cerebrovascular events. In addition, Māori had almost double the percentage of individuals with the most severe form or fully dependent cerebral palsy. This results in a greater impact on the whānau to provide support and care, as well as a greater requirement for rehabilitation, healthcare services, and equipment. HIE, or hypoxic ischemic encephalopathy, is a complication of birth that results in reduced oxygen delivery and impaired blood flow to the brain, which causes a prenatal CP in term-born infants. Māori with pre- or perinatal cerebral palsy are more likely to experience HIE compared to non-Māori. ACC funding was also investigated, and only those born in New Zealand were included in this portion of the study. It can be seen here that Māori are more likely than non-Māori to receive ACC funding. However, the overall numbers of both groups were very low, indicating that the needs of the community might not be met, especially with the deprivation statistics that we saw and the severity statistics. Another interesting point is that 80% of non-Māori received ACC funding due to a pre- or perinatal CP event versus only 44% of Māori. Further understanding surrounding ACC predictors and allocations of funding is needed as part of the commitment to ensuring health equity for Māori in NZ. Now we will be examining how kaupapa Māori principles can be used with this current knowledge to help inform health equity strategies for the Māori population. These principles were created based on prior academic work conducted by some TKHM staff members and Māori academics. They are referenced here at the bottom of this slide. Our kaupapa Māori principles fall under three broader categories: whanaungatanga, manaakitanga, and kaitiakitanga, which have been established as approaches that aid in the inclusion and retention of Māori participants in longitudinal research, a study conducted by TKHM staff members. Firstly, whanaungatanga is a core principle in Te Ao Māori and translates as the practice of building relationships. As I started this talk with my pepeha, in Te Ao Māori it's very important to understand one another's whakapapa and to form connections. In the context of how this can be applied to the NZCPR, allowing time and space for relationships to be built between the research team and the participants is crucial. For example, having the NZCPR presented in a kānohi ki te kānohi or face-to-face way and with continual engagement will strengthen the trust between Māori and the NZCPR. Being admitted to this register requires patients and their whānau to hand over information. Therefore, the NZCPR must build foundations of trust and transparency in this relationship. Secondly, the principle of manaakitanga encompasses the ideas of being caring, being sharing, respectful, and nurturing in relationships. For the NZCPR, this means that the relationships that were established in whanaungatanga must be continually nurtured and upheld throughout the entire relationship. In addition, the NZCPR must act in a way that helps achieve equity for Māori and aligns with the goals of Māori tangata. Ensuring that the nature of this relationship is not one-sided and Māori are mutually benefiting will uphold this principle of manaakitanga. Lastly, kaitiakitanga means to protect, to guard, and to serve. In research, this idea is crucial as it underpins the whole meaning of research, to protect and serve others in a way that will be beneficial to them. The NZCPR has a duty to protect and serve the Māori community from which they gathered information from. In addition, the NZCPR should be maintaining engagement with Māori and ensure that Māori are being enabled the self-governance when it comes to research about their tangata under Article 4. Engagement should not only occur with Māori participants, but also Māori whānau, Māori researchers, and Māori colleagues. There's also a duty to ensure that Māori are not being blamed for the inequities that exist within cerebral palsy, and that the NZCPR commits to conducting research that examines the socio-economic causes of cerebral palsy inequities. This is the first study ever done in Aotearoa, New Zealand, that attempts to describe the demographic and clinical features of Māori and non-Māori individuals with cerebral palsy. From this, we can see that Māori are more likely to be living in more deprived areas and have more severe forms of cerebral palsy, although this latter point hasn't been reflected in other larger group studies on the register, potentially indicating that the register is more likely to recruit individuals with more severe forms of cerebral palsy and not fully recruit those with more mild forms. Full ascertainment of individuals with cerebral palsy in the Auckland metro regions was not achieved. The NZCPR has only been established for 4 years and more time is required to achieve full ascertainment, thus enabling greater prevalence studies. Unfortunately, this under-ascertainment has resulted in small numbers when reporting. Therefore, it's unsure if all the reported statistics are fully representative. As stated previously, the register needs to continue to work towards full ascertainment through the use of kaupapa Māori principles and also a closer relationship between cerebral palsy diagnosis and addition into the register, because right now they do not occur in concurrence. The kaupapa Māori principles are to be turned into actionable strategies that can be conducted and monitored by the NZCPR to ensure Māori participation and contribution for all future research. Already since this work has been conducted, there's been 2 research submissions to date that build on current knowledge. Firstly, there was an HRC application with Dr. Karen Wright of TKHM to build relationships that enhance Māori recruitment into the NZCPR. Secondly, there's a research proposal that investigates respiratory health in tamariki with cerebral palsy in New Zealand. I'd like to say tēnā koutou, thank you very much for your time, and I'd now like to welcome any questions.
Brilliant, thanks Georgia. A very, very quick run through what I'm sure was a huge amount of work for you and your colleagues. So there's been a question already about the slides. The slides will not be made available after the talk because the team is in the process of publishing the findings. But you're welcome to watch the recording slowly. And I know that there's been a rich chat going on in the chat box. Georgia, you don't need to worry about that. I think people are questioning and answering themselves quite nicely, and your colleagues are chipping in there. So there's one question on the Padlet page, Georgia, that I'd be interested in you, or perhaps your wider team, in answering that around the limited numbers of under 5-year-olds that are in the data set. That might be a registry question.
And also, I'd just like to say that cerebral palsy diagnosis isn't always confirmed until age 5. So that might indicate a low ascertainment in that area, but also open to the team answering that.
Perhaps use the emoticons, by the way, while the team member is just answering that, to indicate that you have a question. So put your hand up by clicking on the reactions button at the bottom of your screen.
Thank you, Georgia. Great presentation. Fantastic. Yeah, the register confirms people onto the CP register when they are age 5. So to allow for changing diagnosis in the early period, which is why we don't actively recruit for those ages, although, you know, we'd like them as soon as people have a diagnosis. So that's why the numbers are smaller.
I presume that impacts on the severity, the level of severity on the register as well. The more severely affected children are more likely to go on the registry early. People?
Not necessarily.
Okay.
Not necessarily. It's a bit complicated, but sometimes they hang on to their diagnosis of being born at 24 weeks as premature, and then actually get a diagnosis for a long, long time. So it can be variable.
Thanks, Anna.
Given that, sorry, I didn't know how to put my hand up. I've only got a plus sign or a clap. So my question's a little bit in relation to that, Georgia and Anna, given that you're talking about the inequities and the challenges of not diagnosing and formally diagnosing until the age of 5, and we know about neuroplasticity and everything, is that late diagnosis linking in another study about, or not necessarily late diagnosis, but confirming the diagnosis at 5, linking into other studies that may impact on the proposals that you made, Georgia, about the next steps for the register?
Mm-hmm. Well, interestingly enough, I'm doing an honours research project this year that looks into muscle volumes of infants at ages 3 months and 6 months. And from that, we're hoping to see that it might be possible to detect changes in muscle volume and motor development at these very young ages in order to optimize that neuroplasticity, in order to optimize trajectories of muscle development from a very young age. So it is very optimal to identify the diagnosis young. However, there's a lot of changes that occur in these first 5 years, and there is current research being done to look into that, yes.
I might just add, Jane, to clarify. So it is a registry sort of administration thing for international registries to confirm someone on a registry at age 5. It doesn't mean they're diagnosed at age 5. But all international registries go back at age 5 and check, is the diagnosis still right? And then you are confirmed to be on a register. But our average age of diagnosis is around 19 months or 20 months, I think, possibly across the cohort. So we have younger children, but technically if you're being reported, say, on an Australian CP register, it's once you're confirmed at age 5, and that's just a international sort of standard. So
thank you. I guess I was meaning about thinking of the things that Georgia was saying about inequities of, or potential inequities of care because of the socioeconomic status and the higher number of children of Māori descent presenting with complex CP, and those early years being so critical. I was just thinking if there was some linkage or research happening there. But thank you for clarifying about the register.
Thanks, Jane. Are there any other questions for Georgia? Karen would like to know, Georgia, are there any studies that you know of looking at equity of access in general to ACC?
Yes, so when we identified these results as a team, it was very obvious to other TKHM, particularly staff members, that the area of ACC funding is something that is discussed widely within those circles. It's not particularly my area of expertise, but there is definitely indication of inequities existing in ACC funding for Māori communities. So we're hoping that this data that we've collected just sort of adds to the current knowledge about those inequities.
Thanks, Georgia. Probably got time for one more question.
There's a couple more in the Padlet, in the chat. So one from Emma, wondering if paediatricians are adding these children to the register when they're diagnosing them. And from Sam, maybe this is a question for Georgia, because perhaps Anna, you could answer that first one. How do your findings...
Jane, I wonder if we just jump to that last question from Sam. The other one from Emma, I've put on the Padlet page actually, because I think that's something that a lot of people listening to the recording will be interested in, about the way data is collected with the registry. Anna, you might also want to check in on that and answer it. So from Sam, how do your findings with decile data compared to the general decile data from those areas by ethnicity?
So on the Ministry of Health website, the general decile data is similar to other data estimates about Māori populations and living in those deciles. So the traditional New Zealand deprivation graph for Māori is on a steep curve from the areas of least deprived to the areas of most deprived. And in general, our Māori population does follow that. It's just definitely a great concern, understanding that Māori have very severe forms of cerebral palsy and are living in areas most socioeconomically deprived when they are actually in need of more access to care. So they are similar to general decile data.
Thanks, Georgia. And so I'll have the last word. Georgia, what's been your take-home message as an emerging doctor for the way that you practice in this area?
I think that in medical school we're always told about how Māori suffer more inequitable forms of health. However, just seeing the data myself and holding it and being the one calculating it made it a lot more real. And when you see the inequitable health along with the decile statistics and the severity, it paints this picture showing that quite how severe this health crisis is for Māori in New Zealand, and that if we see it in CP, we'll see it in a lot of other health cases as well.
Nothing like it really hitting home, eh?
Yeah, it's definitely very eye-opening.
Well, thank you so much, Georgia. So Georgia's contact details are on her introductory slides, and we're, as a community, we're all watching and waiting with a bated breath to see this in print and to read the full story. So reminder again, the Padlet page stays open, the discussion board, it's in the chat box, and you're welcome to engage in that for the weeks, months ahead. That will remain live, and we will continue to keep Georgia and team linked into that. As I said, this is the first of regular monthly lunch and learn sessions from the Paediatric Society of New Zealand, and we'd just like to thank you for your engagement in this inaugural session. So next month, same time, we have the F Words Life Wheel by Arul Hamill and Lucy Charles, two really experienced clinicians in Auckland, as a strengths-focused goal-setting approach for working with children. So might see you again then. All very welcome. So thanks for signing on. Ka kite anō, and we'll see you again.